So good afternoon. I'm Dr. Dale Bratzler. I'm the Chief Quality Officer here at OU Health, and I'm also the university's Chief COVID Officer. I'm going to give a brief update of where we're at with respect to the pandemic, and I know that there are a lot of questions today about the Omacron variant that now is spreading around the world. So I do have a handout that will be distributed, and it has all the information that I'm going to talk about, at least in my prepared comments. So as of this morning, Oklahoma ranked 33rd in the nation at about 18 new cases per 100,000 per day in our population. Now, to put that in perspective, on August 30th, we were at about 66 new cases per 100,000 population a day. So we're dropped down to 18. There has been a steady decline in the number of new cases per day in Oklahoma. And I included a national map that again shows that it's our northern states, Michigan in particular, Minnesota, Wisconsin, but also Colorado, New Mexico, and others that have seen substantial increase in the number of cases. The CDC this past week reports that we had about 185.6 new cases per 100,000 per day, so that ranked Oklahoma 28th in the nation for new cases over the past week, and I included the CDC map in the handout that shows that Oklahoma is not in the lowest performance rate right now with new cases. So let's go to where we're at in the state right now. As of today, 585 new cases were reported by the state health department. There were 102 new deaths reported in the past 1 week period here in Oklahoma, and the death rate still remains right around 1.8% of those people who have a positive test. That's the percentage that actually die. Oklahoma remains 6th in the nation for the highest rate of death per capita in the nation. So again, we're also very high on the total number of cases per capita. So Oklahoma still has had some real challenges with this particular epidemic or pandemic. I wanted to highlight the two rolling average slides that I included in the handout today. I included both the 3-day rolling average and the 7-day rolling average. The good news is that both are still trending downward. If you look at the 7-day rolling average, which is the number I focus on the most, today we're at 756 new cases per day in the state. About 2 weeks ago, we were right around 850. So we've dropped about 100 new cases per day over the past 2 weeks. So that's good news that number is trending downward. It's slow, but it is trending downward. And I think we have to keep very close track of that. I think many of you know that we have seen some increase in hospitalizations. As of this morning, we had 482 Oklahomans in the hospital with COVID-19, 151 of whom were in an intensive care unit bed. Throughout the pandemic, we've been seeing fairly consistently about a third of the patients who are positive and end up in the hospital with COVID-19 are in an intensive care unit bed. So again, we will continue to see more deaths as long as we have that many people who are that sick with COVID-19. And then the last of the update slides is the community transmission rate. This is a map that's produced usually every day by the CDC. So today's data goes through yesterday and shows that there is some color now in Oklahoma. Most of the state remains in the highest or red transmission rate zone, but we do have a few counties now that are in the moderate transmission zone or yellow, which is where CDC says that once your county gets down into that level, you can consider reducing some of the mitigation for COVID-19. Most of the state, though, is still either orange or red, so we should continue to wear masks when indoors, particularly in poorly ventilated settings. So let's talk about some of the other medical news this week. And I highlight in the handout, you'll see that I provided a slide. It was the last slide that I gave in a recent presentation about COVID-19, but I ended my presentation after I had talked about all the good things that have happened and how cases have come down. What could go wrong? And I highlighted two things. One is that more than 50 countries in the world haven't even hit 10% vaccination rate. And that's where we will see continued unmitigated spread of the virus. And when you see spread of the virus with multiple people getting infected, you see mutations happen. And in fact, in that presentation, I highlighted most of those countries are in Africa, where the World Health Organization says that of the entire continent, only 4.4% of the population of Africa, the continent, is vaccinated. The other point I made was that one of the public health tenets of eliminating viral diseases is that you cannot eliminate a disease if there is an animal vector for the disease. And of course, there's been a lot of news about white-tailed deer, a lot of them being infected with COVID-19. And again, there hasn't been any documented transmission from deer to humans, but if the virus is in the environment, spreading through deer, and it can spread and mutate, it is possible. It is possible down the road that we could see some transmission of the virus back from deer to human. So it's something we need to watch very, very carefully. But again, I don't think any of us think that we will eliminate the virus that causes COVID-19. We hope to suppress it to the point and to get enough people vaccinated that it doesn't spread easily, but we will see periodic outbreaks going forward. We won't eliminate this particular disease. So obviously the big news this week then is the Omicron variant, and some people have asked about the pronunciation. I actually had to look it up. The United States pronunciation, or the English pronunciation of this particular Greek alphabet letter, is Omicron. However, the British pronunciation is often Omicron. You've heard it both ways in the news, and either way is considered appropriate. So this particular variant was first identified in the country of Botswana, which is just north of South Africa, and then just a few days later, they started sequencing this virus in South Africa. It's now been identified in 17 different countries, and I honestly very much believe that shutting borders down, probably it's too late at this point. It's like closing the barn door after the horses have already left. We're well beyond that. I just wanted to highlight that Botswana, only 22% of their population is fully vaccinated, and South Africa, only 24% is fully vaccinated. So again, think about the points I made earlier about Africa having very low vaccination rates, and I think that's where we're going to see spread of the virus. And anytime you see the virus spreading a lot and a lot of people getting infected, you increase the likelihood of mutations. So what do we know about the Omicron variant? Well, it has 50 different mutations from the original virus that came into the United States from China. 30 of those mutations are on the spike protein, and that's caused all sorts of problems that I'll talk about in just a moment. Some of the mutations that have been seen on the Omicron variant are very similar to those seen on the Delta variant that makes Delta very contagious. And so that's one of the big concerns, that this virus has mutations that will allow it to attach to human receptors easily and potentially make it more contagious, spread easier from person to person. Again, I included a quote from Dr. Francis Collins at the NIH director, and he highlighted, we just don't know yet what's going to happen in the United States with this particular variant, because our country was completely overtaken with the Delta variant, and we just simply do not know whether the Omicron variant will, displace the Delta variant. We just don't know at this point. So it's too early to predict what may happen. The other thing is, remember, I just highlighted that in the countries that are seeing rapid spread of the Omicron variant, they have low vaccination rates. And while the United States isn't great, we're more than 60%, or right at 60% fully vaccinated in this country, which should potentially slow the spread of this particular variant. But there are a bunch of unknowns about this particular variant. Will it cause more severe disease? We don't know at this point. One thing we do know about viruses is that when they mutate, if they mutate to a form that causes more severe disease, in other words, kills the host, then they don't spread nearly as rapidly. We saw that in 2003 with SARS, the original SARS outbreak that happened, because the virus was so lethal that it burned itself out very rapidly because it killed people who got infected. They didn't have the opportunity to go out and spread it to other people very much, and we rapidly contained that particular virus. So we don't know about this one, but so far the early indications are is the disease probably won't be any more severe. The second unknown, will it replace Delta variant? Again, we just don't know. The United States has right at 60% vaccination rate, full vaccination, and we're now pushing out boosters to a large part of our population. So we have no idea. Will Omicron go about spreading in the United States as fast as it's doing right now in South Africa? And then the most important questions, will this particular variant evade the protection that you get from being vaccinated? Will it evade that? And I'll talk more about that in just a moment, but we just don't know yet. Most of the companies that make the vaccines now are doing tests with the genetic strain that's causing this particular outbreak, but we don't know. And then the other unknown is, will this variant evade the protection, the therapeutic benefits that you get from getting monoclonal antibodies? If you were to get infected, will monoclonal antibodies then be an effective treatment to keep you out of the hospital and from having complications? Now, I just wanted to highlight that when you look at some of the work that's been done on variants around the United States, they had, in many laboratories, tested different mutations. They, in other words, they created a virus that could not spread, but they tested the variants by creating mutations on the spike protein and other parts of the COVID-19 virus. And what they showed was that the antibodies produced by current vaccines might not be as effective against these mutated forms of the COVID-19 virus. So in the laboratory, there is real concern that with all of the mutations that you see on this particular variant, that the antibodies that are in your blood after you get vaccinated may not be as effective as they were against previous strains of the virus. So it's important to know that there is real concern by experts that have been doing the virology, looking at the mutations, but we just don't know what the overall impact will be yet. So, highlighted, right now, CDC reported that they're testing about 40 to 80,000 specimens per week in people who test positive for COVID-19 for variants, including now Omicron. So if it's in the United States, it probably won't take us too long to actually find that.
So I want to interrupt you for a second because my phone's blowing up, that evidently the CDC just announced that the first case is in California.
Okay, so April's telling me that CDC just announced that the first case of the Omicron variant has been identified in California. No surprise here. And again, I've highlighted this in other presentations or press events this past week, that closing borders is almost always too late. We already knew it was in Europe. There was no restriction of travel. We already knew it was in Korea. We already knew it was in Australia. There was almost no way that we were going to keep it out of the United States. You just simply cannot contain a virus with borders anymore. That just doesn't happen for a respiratory virus that spreads easily. So, not surprising. Thanks for interrupting me and letting me know that. But again, as long as this virus, and I'm not talking about Omicron, but I'm talking about the COVID-19 virus, can spread unmitigated through populations, as long as we have populations in the world that are not vaccinated and it spreads easily, we can see new variants of this particular virus. So that then takes me to, I think, one thing, just a single handout page that I highlight, treatments for COVID-19, because I think the treatments are going to end up being very, very important for reducing the burden of this particular disease. So we have two different forms of treatments that have been shown, proven in studies to change outcomes for people who get COVID-19. And the first is monoclonal antibodies. We use them in people who test positive, and in people who test positive, they've been shown to be 70% or so effective at preventing hospitalization and death with at least the current strain that's predominant in the United States. Post-exposure prophylaxis. So if you're somebody who is exposed to somebody, maybe you live with somebody that now tests positive and you have underlying disease that would put you at risk for the complications. Post-exposure prophylaxis, even if you don't have a positive test, can reduce your chance of hospitalization by 75%. So really, really important to keep that in our back pocket to use monoclonal antibodies, because even if we can't stop completely the spread of the disease, at least those people who get infected, hopefully we can keep them out of the hospital and from dying. But then there are two new antiviral medicines. Merck's molnupiravir, which was given a recommendation by the FDA advisory panel yesterday, a very slim vote, 13 to 10, that they recommended that FDA give emergency use authorization for molnupiravir, which is an antiviral medication that has to be started within 5 days of the onset of symptoms of COVID-19. So a person tests positive, they have symptoms, you start them on this pill, this medication for 5 days, and it will reduce hospitalizations and death by about 30%. And that's why FDA was lukewarm on this particular recommendation. The original data that Merck had provided suggested a 50% improvement reduction in hospitalizations and death, but their most recent data shows that it's only about 30%. And just to highlight, this particular treatment for COVID-19 will not be recommended in pregnant women or people who are breastfeeding. But then the second drug that's been submitted to the FDA for approval comes from Pfizer. It's called Paxillavid. You have to take it with one of the old HIV medications called ritonavir. So you take 3 pills twice a day for 5 days, ideally started within 3 days of the onset of symptoms, but it was 89% effective at preventing hospitalization and death. So again, I think it's going to be very, very important that if we see spread of Omicron that is now in the United States, and if we start seeing it spread pretty quickly, then it's going to be really, really important that we have treatment in our hip pocket to keep people out of the hospital and to keep them from having severe complications of the disease. The two different drugs, Merck's and Pfizer's antivirals, work by different mechanisms. I think it's likely that the Pfizer drug may be approved in pregnant women or breastfeeding women, but clearly Merck's molnupiravir will not be recommended in pregnant women. Lastly, I'm going to end with something I always talk about. There are certain mitigation strategies that are universally effective for all strains of COVID, regardless of variants, mutations, or anything else. And a nice study was just published in the British Medical Journal, a large systematic review and meta-analysis, and I've included a couple of the graphics from that particular article, but the ones that showed to be very effective are wearing a mask, hand hygiene, and social distancing. If you look at the particular study, hand washing, mask wearing were more than 50% effective at preventing infection with COVID, regardless of which variant we're talking about. Mask, physical distancing, hand hygiene are universally effective to prevent the spread of this disease. We have to keep remembering that. It also prevents influenza. So I'll stop there.
Okay. So you said that the CDC is testing thousands, I can't remember what the number was,
Yeah, so
and they're looking for the Omicron plus the other thing.
they're looking for all the variants. So CDC announced that they've really ramped up their variant testing capacity. So they get specimens that come in from public health laboratories from all over the country, and they're right now testing between 40 and 80,000 specimens per week, doing genetic sequencing, looking for variants. So as I expected, I didn't think it'd take us long to find Omicron if it was in the United States, because they are testing quite a few specimens.
So that includes testing Oklahoma specimens.
It does include testing some Oklahoma specimens. You know, I don't know, I think most people are aware Oklahoma's had relatively low rates of testing for genetic variants, but CDC is doing nationwide surveillance.
So it's really just a matter of time, you think, before it makes it to Oklahoma?
Hard to know how fast. You know, one thing I've highlighted in a couple of discussions lately is, remember a couple of months ago or so, we were really concerned about the new variant that came in, and we saw 15 cases in Oklahoma really quickly, and then it stopped. No other new cases in the entire country of the mu variant. So I just can't predict what's going to happen with this particular variant, but if it does spread, if it's like Delta, sure, we'll see it in Oklahoma.
If Omicron's symptoms are mild, wouldn't this be a strain I'd rather get than another mutation that could be tougher to get through?
Well, I would say the data on severity of illness is quite preliminary. So the report that came out of South Africa saying that most of the cases were mild was by a clinician who had a largely younger population of patients that they saw. And that's the same that we see in Delta variant. Young people tend to get cold-like symptoms, flu-like symptoms, but are much less likely to be hospitalized. I think it's way too early to know how severe disease may be with this particular variant, and I just have to remind everybody that age is the biggest predictor of bad outcomes from COVID-19.
How do they know when a new variant has arisen? I mean, how do you know that first case is a new variant?
Yeah, so with this particular variant, there were a couple of things that happened in the laboratory. So typically they test for different domains of the spike protein, and one of the domains came out negative on this particular virus when the other two were positive, which was a red flag that something was different about this variant. Second, they started looking specifically because they had patients who were fully vaccinated that were now having breakthrough infections, and they wanted to see what the variant was that was causing those breakthrough infections. So the combination of those two things, a marker in the laboratory that all of a sudden they had a new strain, that one of the tests was coming back consistently negative while two other tests for domains of the spike protein were coming back positive, it was a red flag that there was something else going on.
Let's hold on a moment.
We have a helicopter landing on our roof right now.
This is kind of a philosophical question. I mean, there's always been new variants, and what would you say to Oklahomans about the future of our health? Is COVID-19 something that we will deal with for the rest of our lives?
Yeah, yes. So the question is this something we're going to deal with for a long time to come? And the simple answer is yes. This will become an endemic disease eventually, where there'll be pockets or outbreaks or clusters that occur, particularly among people who are either not vaccinated or who have some immunocompromised state. But, you know, I think I've been clear in previous discussions that for the students, the medical students here I teach, I basically highlight that this will be in the differential diagnosis of a patient that comes in with a respiratory virus, I think for years to come. And again, it's part of why I highlighted that because we know there are animal vectors of this virus, it's simply not going to go away.
So what's your message to those who are on the fence or hesitant about getting the COVID-19 vaccine at this point?
Well, certainly, even before any of this, I would have highly recommended following CDC recommendations, getting vaccinated, 2 doses of the RNA vaccines or a dose and a booster of Johnson & Johnson. I think for me now, this has highlighted the urgency to get a booster dose. Again, I think on our last press briefing, I talked about tetanus. You take the shot 5 times as a kid to build up immunity, and then we give it every 10 years. None of us should have ever expected that a single priming series a vaccine against COVID was going to protect us for life. And now we know that even if you're fully vaccinated, you can have a breakthrough infection because vaccine immunity does wane over time. So I strongly encourage everybody to get that booster dose. And I think there's pretty good reason to believe that even if the vaccines don't completely protect you against the Omicron variant, they will do things that we see all the time, which is reduce your chance of being hospitalized or having severe complications. So I strongly encourage people to both get primary vaccine series and then to get the booster.
On the numbers, the Oklahoma numbers that you're giving, is it too soon to actually say we have post-Thanksgiving COVID numbers?
Well, certainly right now. So the question is, are we seeing post-Thanksgiving COVID numbers? The reality is the cases are still declining in Oklahoma despite Thanksgiving. However, I think it is a little bit early. Typically, remember the incubation time for the Delta variant, which is the predominant strain in Oklahoma, is 3 days to 5 days. It's shorter than the original. But then it's usually a day or two or three before people start having symptoms. So I think if we're going to see an uptick in cases because of Thanksgiving or the holiday weekend, we really won't see that happen until this coming weekend and the first few days of next week. That's when I would start to see higher positive rates, more people testing positive, if we see a surge because of Thanksgiving.
This one is, I know you're not an economist, but can you speak to how the variants hurt us economically?
Yeah, so so definitely not an economist, but you know, I think we saw it happen the second the Omicron variant was reported from South Africa. The markets crashed because everybody's concerned that if we have a highly contagious variant that spreads around the world, if we see another Delta surge, like Delta-like surge in Oklahoma over the next few months, it just has a profound impact on the economy. It reduces jobs, it keeps people at home, it takes people out of the workforce, just huge financial implications. I was reading an article before I came up here on some of the patient-level financial implications of these infections, because many insurance companies now consider COVID-19 to be a preventable disease because you can go get vaccinated, which typically will keep you out of the hospital and from having complications. And so they're not waiving co-pays, deductibles, and those types of things anymore. And so the average bill that a typical patient gets that has COVID, particularly for all the ancillary services, is $3,000 to $4,000 per case, and it can be much, much higher for somebody that's in the hospital.
Speaking of hospitalization, so we talked about Oklahoma's hospitalization numbers. Are the people that are coming into the hospital, are they more ill than they were in the past, or is it the same?
Yeah, I would say I haven't seen any substantial change in the severity of illness of those patients who do end up in the hospital. Again, the one number that's been very consistent throughout the pandemic is that about a third of the patients end up in the ICU, and that just simply has not changed. The mortality rate has trended upwards a little bit. So I followed it for a long time, and it was around 1.7%. It's now clearly up to 1.8% and still appears to be going up a bit more at this point. That may be because vaccine immunity is waning, more people that are getting infected. We obviously are less vigilant about wearing masks, physical distancing, and other things that could prevent the spread of the disease. And again, age is the biggest risk factor for both hospitalization and complications of the disease. And with vaccine waning of immunity is probably even more common in the elderly.
And so besides just the vaccine waning, not getting the boosters, we still have a relatively high number of unvaccinated in Oklahoma?
Yes, so if you look at the entire population of Oklahoma, I believe only about just around 50% are fully vaccinated. If you include the entire population, if you go 12 and up, it's approaching 60% full vaccination rate based on CDC data.
Are breakthrough cases being seen more?
Breakthrough cases are common. So I looked at the weekly epi report from the state health department yesterday. If you look at people who come into the hospital, who actually get hospitalized, about 25% of them are vaccinated, either partially or fully vaccinated. That's almost identical to the very large study that I've highlighted in the past from Los Angeles County that showed that of all the new infections for COVID-19, 25% were occurring in fully vaccinated people. I think a lot of people have heard that breakthrough infections do appear to be relatively common, up to 25% of the time. However, those patients are much, much less likely to require hospitalization or death if they do get COVID-19.
The last question I have is, do you think boosters will be cleared for those 16 to 17?
Yeah, so FDA and CDC will be making recommendations shortly on the delivery of booster doses to people between the ages of 16 and 17, and I see no reason why they would not approve that recommendation.